In this section, we will go through the surgical interventions that are linked to peptic ulcer disease. There are 3 surgical procedures which are used to treat peptic ulcer disease surgically. First is gastrectomy, in which a section of the stomach is removed, the rest is anastomosed. This is done by Bilroth 1 and Bilroth 2. It helps in decreasing the gastric acid production. Gastrojejunostomy, in which the stomach is anastomosed with the jejunum, and vagotomy, in which the vagus nerves that supply the parietal cell are transected. These are often followed by drainage procedures. Gastrectomy is of 2 types, Bilroth 1 gastrectomy and Bilroth 2 gastrectomy. In Bilroth 1 gastrectomy, we simply excise out the antrum of the stomach. Stomach has 4 parts. The fundus, the body, the antrum, and pylorus. Antrum not only produces most of the gastric acid because it has a lot of parietal cells, but it is also the most common site of ulcer. So its removal not only removes out the ulcer but also helps in the reduction of gastric acid and so prevents further peptic ulcers. Bilroth 2 gastrectomy, not only the antrum but the distal part of the body is also removed out. The stomach, this pink is duodenum, and this green tube shows jejunum. This antrum as well as some of the distal portion of the body of the stomach is removed, and instead of joining it to the duodenum, it is joined back to the jejunum, and so gastrojejunostomy is done. Bilroth 1 is the preferred procedure and Bilroth 2 is done only when the disease is extensive. Bilroth 2 decreases gastric acid much more than in case of Bilroth 1, but it involves 2 anastomosis and is more invasive procedure than Bilroth 1. In gastrojejunostomy, simply the jejunum and stomach are fused through an anatomical shunt. An incision is made in the stomach and as well as in the jejunum. Both these are fused together such that there is an open passage between the two. In this way, the bicarb present in the jejunum can move up into the stomach and help neutralize the gastric acid. But this procedure has been abandoned since the gastric acid can move down and cause jejunal ulcer. Vagotomy simply means the transection of the vagus nerve supply to the stomach. The stomach gets its parasympathetic supply from 2 vagus nerves. These help the stomach to produce gastric acid, helps open the pyloric sphincter so that food can pass down, and along with these, it helps to increase the volume of the stomach by decreasing the stomach tone. There are 2 vagus nerves, posterior and anterior. Both are transected in vagotomy, but for simplicity, we'll consider the posterior vagus nerve here. It gives off hepatobiliary branches to the liver and gallbladder and then branches to the celiac plexus. When it moves down, it supplies the parietal cells that produce gastric acid, and at the end, it supplies the pyloric sphincter. It helps open the pyloric sphincter and helps in food efflux. So in truncal vagotomy, we transect the trunk of the vagus nerve. It cut off supplies to the gallbladder, and so gallstasis occur and stones occur in the gallbladder. It can also result in dumping syndrome due to the increased stomach tone that will be explained later, and no relaxation of the pyloric sphincter causes food stasis within the stomach. Another type of vagotomy is selective vagotomy, in which it is transected after it gives off hepatobiliary and celiac plexus branches. Then there is highly selective vagotomy, in which only the small branches to the parietal cells are transected. It is most preferred. In truncal vagotomy and selective vagotomy, The nerve supply to the pyloric sphincter is cut off, and so it does not relax and gastric stasis occurs. Therefore, drainage procedures are done after vagotomy, known as pyloroplasty and gastrojejunostomy. These help to prevent gastric stasis so that food does not remain in the stomach and it can easily pass down into the duodenum. Pyloroplasty simply means widening of the pylorus. Gastrojejunostomy is anastomosis of stomach to the jejunum. Pyloroplasty, a longitudinal incision along the pylorus is applied. It is opened and then sutured back in a transverse manner. This helps to open and widen the area of the pylorus, and so even after vagotomy there is no gastric stasis and food can easily pass down. Gastrojejunostomy is done in the same way. Here it helps to bypass the constricted pyloric sphincter after vagotomy, and food easily bypasses it and directly enters from stomach into the jejunum, and so there is no gastric stasis. He is a patient of rheumatoid arthritis and has been using NSAIDs for long term. This is the risk factor for peptic ulcer disease. Then her symptoms like abdominal pain, signs like tenderness, distension, and tense abdomen shows peritonitis, along with toxicity also indicate peritonitis, like a high pulse, decreased BP, and increased TLC count. So in this scenario, her long-term use has led to peptic ulcer disease, which finally perforated and the contents oozed out into the abdomen, leading to peritonitis. In surgery, almost all the scenarios of the past papers are of perforated peptic ulcer, just like this one.